So, good evening, everyone, and welcome to today's educational initiative by the Indian School of Urology. And it is on a paradigm shift in BPH care and how UroLift continues to deliver consistent durability with superior patient experience. And the main speaker for today is Dr. Kiran, Hazratwala, and he's the consultant urologist, Northern Urology Clinic at Australia. And with him, we have two moderators, Dr. Sanjay Pandey, who is the consultant urologist and head of the department at Kokila Ben Hospital in Mumbai, and Dr. Abhishek Singh, who is also consultant urologist and the lead faculty at Muljibai Patel Urological Hospital, Nadia. So I would hand over the proceedings to Dr. Madhu, who would introduce the speaker, and then to Dr. Sanjay and Abhishek can take it forward. Please put your questions in the chat box, and the speaker would address them as soon as the meeting is over. Thank you.
Thank you. Thank you, ma'am. I would like to Dr. Kiran Swam. Dr. Kiran is a consultant, as you told, Northern Urology Clinic.
Your voice is breaking.
Can you hear?
Not much.
Oh.
I think, if anything, Dr. Sanjay does know me well enough to introduce me, I think.
I wish they had put up a slide, Anirudh. That would have been such nice. We're doing a great educational program over the ISU, USI. So, Anirudh, do you have a slide for us to see? Because there are colleagues and there are our students and everybody in the audience. Dr. Madhusudan, your voice is cracking. You are probably in a different location.
Dr. Maddy, can you please share?
Meanwhile, if he has a slide, Anirudh, that would have been great. There would be no introduction required for a faculty who has done wonders today morning and has made me feel completely different to what I've been doing. Wonderful. Thank you so much for this. Can we enlarge this slide, please?
So I think then maybe Sanjay, you can introduce him briefly.
Yes, I will. So good evening, everybody. I think this is historic for many reasons for prostate therapy in future. We will know from the talk that Dr. Kiran Hazratwala does speak about, but to take you forward on the journey on this epoch-making attempt that we are doing to look at a paradigm shift in prostate therapies. Dr. Kiran Hazratwala was there today morning with us, and I introduce him with a lot of respect. He is a private consultant urologist at the Northern Urology Clinic in Australia, graduated his medicine from the UNSW and completed his advanced training in urological surgery in Queensland, and has a subspecialty fellowship in prostate oncology from the Royal Brisbane Hospital. Dr. Hazratwala has profound experience in the management of adult urological conditions and has completed over 700 UroLift system cases that has successfully integrated into his own practice. He has presented and consulted with urologists nationally and internationally regarding the expert peer-to-peer guidance on a UroLift topics to many procedural tips. That is on the slide, but give me a minute to introduce him at a very personal level. I have heard of him, I had known about him, but when I met him today morning at 8:55 a.m., over the last 25 years of my urology and into the last n number of months deep into UroLift, the amount of practice patterns that he had on the procedure for us to give tips and tricks on one single case we did today morning made me convinced, and I had to tell him that you actually moved mountains in the kind of practice we people do. So Dr. Hazratwala, the stage is yours to take it forward to our colleagues in urology that minimally invasive surgical therapy for prostate on chosen indications is such an important need. I, over the last 1 year, took up this subject, and many of my colleagues in various parts of the country have taken it forward. But maybe your tips and tricks, your talk on this huge mammoth experience that you have over 700 cases, which showed up so tremendously in the operating theater today morning, would actually help a lot of colleagues to get convinced on the kind of Indianization of various indication that we need to look into and bring it that as a part of our therapy and take it forward in the treatment of modern urological patient and the indications that is required to be treated. So Dr. Kiran, good evening to you from the ISU USI platform. And thank you for giving us this important attempt to understand the subject higher than what I understood today morning. Thank you for all the attempt you did today morning. I just feel more convinced compared to what I did for the last 1 year. The stage is yours, Dr. Hazratwala.
Thank you, sir. So good evening, everyone, and thank you. It's an absolute honor. That is the most heartwarming introduction I've ever had for myself, and it's almost worth the trip halfway around the world to come and convince at least one learned colleague to take on Eurolift in a much better manner. So I'm hoping that by the end of today's talk, the main thing to take home will be that we are going to, and the words paradigm shift is mainly in terms of how you think about this treatment as an option for BPH management. And we all have to compare everything we do against something, but it does not have to necessarily be exactly what the other treatment does. I need us to be convinced and understand that this treatment, although being compared as an option of BPH management, stands on its own in terms of how and what it does to provide the outcomes that we desire in terms of prostate obstruction. So, as you know, this is the last time I'm doing this talk in India, and it's an absolute pleasure to be doing it for this crowd who truly this morning, I had the warm and fuzzies. I almost had a tear in my eye because everyone that was there seemed convinced about what we are trying to achieve with this technology. And I hope that this takes on and it will make my trip entirely successful. So I am just waiting. So this is digressing from what I'm going to present. I've got Dr. Madhu has arrived downstairs. So if I can just ask your permission to have a pause for a couple of minutes, here we are. Just give me 1 second. All right. So I'm going to log off from my phone and I will click back on with Dr. Madhu's computer.
Easy, take your time. I will keep it holding till that time. Yeah, thanks.
Thank you.
So friends, yeah, thank you. Welcome back. Friends, looking into minimally invasive surgical therapy, which has touched our shores in the last few years, has been taken up by very senior colleagues in various cities for right indications. We know that we are deeply entrenched into prostate surgery by two major means. One happens to be the TORP, the gold standard of the era that we all were taught, trained, apprenticed, and probably rose and polished to some levels. And then came the entire minimally invasive laser therapy, which again has got the thulium and the holmium, which again are competing with each other and have got their proponents. The minimally invasive surgical therapy comes with a different kind of understanding where your dwell time is much lesser. You are with a scope which is a smaller caliber, like 20 French for the Eurolift, which is in question today. And I think it feels good enough. Are you ready, Dr. Kiran? You are muted, so you can unmute yourself. And we go ahead with the minimally invasive surgical therapy around. Go ahead.
All right, then. So good evening, everyone, once again. Thank you for this opportunity. After that introduction, I will, and I understand how busy Dr. Sanjay is, so I'm going to run through the talk, and I'm hoping to leave enough time for discussion. I think as I've gone through presenting this talk a number of times, it's more important to answer questions that people practically have than me didactically trying to teach people about what to do with Eurolift. So I'll go through the talk and let's have a discussion right after that. So Eurolift system I've been doing for about 8 to 9 years now. I took it on at a time when not a lot of urologists in Australia were undertaking this treatment. And the prime reason at that point was because there was a 60% decrease in the surgeon's remuneration for doing this procedure when I first took it on. So there was not a lot of uptake for a new treatment modality coming through. Now in Australia, the remuneration's doubled and everybody's interested because I don't think they've ever doubted the results. It was the remuneration, and now with the short time it takes to do the procedure, people are very excited about this technology. So let me take you through a little a snippet of how I integrated urology in my practice and what the paradigm shifts are in your thinking. I am a hired gun. I'm a paid consultant for Teleflex, but that is not why I'm doing this. As anyone who's met me over the last week will tell you, I truly believe in the technology. I fell into this proctoring gig as a result of trying to help a couple of friends take on this technology. And with their encouragement, the company has got me talking in a few different places. And here we are today in a place where I was born. So it's an absolute honor. Now, the indications for use. This slide, there's only one thing to tell with contraindication, and that is urinary tract infection. No urologist will ever operate in that situation. But the volume criteria of that 100 cc was based on what the initial lift study put out as the upper limit of what can be treated, together with middle loads at the time when it was initially. I don't truly believe that it is an absolute contraindication. The prostate of the prostate that will make you. Oh, it's great.
My apologies, the voice is breaking all the time compared to your previous login where the voice was smooth. This is like shaking and breaking voice all through. So we're missing on the. Sorry about that.
Okay.
Yeah, I think they can hear you.
Can you hear me? Dr. Sanjay, can you hear me?
Yes, yes.
Beautiful. Okay, so I'll continue with the talk. So as I was saying, the only true indication, contraindication, is a urinary tract infection. And for me, it is the shape of the prostate that's more important than exactly the size of the prostate as a contraindication. So let's start talking about who and where. I'm not going to take too much time on this, but I live in the very north part of Australia. And one of the encouragements for everyone is that it is a very small place. I'm a single solo urologist. I just love what I do. I'm not in a research institute. If I can get some good results with careful planning, it is possible for absolutely anyone. And you guys are in major research centers. You've got all the help available. You will do well. So please come visit Townsville. It's a lovely part of the country. It's the gateway to the Barrier Reef. But only one word of caution: when you come there, do not go in the water. There are some big animals with big, strong jaws, with crocodiles everywhere. So do not step in the water. Can you hear me?
Actually, not very clearly. We
Not
can't
very
hear
clear.
you very clearly.
Dr. Kiran, your login from the phone was awesome in terms of clarity of the voice compared to the clarity which is coming right now.
You can talk. Go ahead.
Can you now hear me a little bit clearer than you were before? Wonderful.
Yeah.
All right. So one of the things about Townsville, as I was saying, I'm not going to spend much time, is when you come to visit, please do not step in the water. It's got some nasty little crocodiles and stuff that can snap away at you. So it's a beautiful place to visit, but there are some nasty animals that we don't meet anywhere else in the world. Anyway, so I have taken on UroLift for about 8 years now. I've got a series of around 700 cases. My hope was to bring you the data from that 700 cases, but that is just fallen a bit short with the registrars taking their time and getting the information together. But we will talk about some of the preliminary results that I've already seen in terms of reoperation rates and such. So it is lovely to see that the impact trial presented at AUA 2024 is starting to mirror some of the things that I've been talking about, and also Brian as well of Texas has been talking about, in terms of UroLift being a replacement for medical therapy as opposed to an option as an interim between medications and doing something that is surgically incisive like a TURP. It's got better symptom relief, quicker return to work, and the patient satisfaction is very high. In terms of patient selection, the LIFT data, the real world study, and the healthcare claims data will all tell you that it is a durable, repeatable, and efficacious treatment. In the paradigm, one of the first things about patient selection paradigms is that instead of saying to them, "How are you doing?" and they'll say, "Yes, I'm okay. I'm tolerating everything," to get them, ask them the question, "Let's look at how you're doing." And the data I get, how I start that conversation is by everyone having an IPSS first. And if there are any symptoms there, you start the conversation about some minimally invasive therapies. That's how I look at it nowadays. Now, this flexible cystoscopy was an interesting aspect, because when I first started UroLift in Townsville, the medical advisory committee at our hospital had me at gunpoint because no one in Australia, very few people in Australia were doing it, and I was wanting to start that in a slightly remote place. And I was heavily scrutinized for the first 30 cases in terms of what I was going to do, how I was going to evaluate them intraoperatively and postoperatively, and what outcome measures I was going to monitor. And so I became very conservative in who I took on and how I selected my patients. And so I started doing a flexible cystoscopy as a part of my evaluation process, and I will take you through how that helps me and helps the patient eventually in terms of selecting the patient better. So at my patient consult, the usual stuff that you all do in terms of making sure the patient is appropriate for this treatment. And this is where the game starts. When they first come to see me, and if they're avoiding symptoms, I start them on a month-long trial of alpha blockers, spend plenty of time discussing some of the side effects of medical therapy. And I schedule a flexible cystoscopy 2 weeks in between that trial of medication, so I can find out how they're doing with the medical therapy, but also then look at the prostate anatomy. And the advantage of flexible cystoscopy is twofold. Firstly, for the patient, I can better counsel them based on their anatomy, what they can expect to achieve or outcome-wise moving forward in the medium to long term. But for me, the advantage in helping the patient was that after I've done the flexible cystoscopy, and my annotations now give me an exact plan for what I'm going to do with every prostate before I even start the operation on the day of the implant. And so we'll talk about 4 prostate shapes and 4 plans for how that mirrors in terms of how you're going to do the implant. I give the patients lots of information that the Teleflex team will have for you that you can give them, instead of letting them look into the Google for somebody's blog that usually confuses them more than convinces them. Trust is then urodynamics are an option. Guys in Bangalore do that every case, which is probably a very safe way to go for the Indian setting. But in Australia, I only do the urodynamics if someone fails to improve after what, in my opinion, would be bladder outflow obstruction treatment. Now, here we go with the procedural tips. And this is not going to, a lot of this is going to sound trivial, but it is important. After you do a few cases, everyone sees the benefits of what I'm trying to say here in terms of procedural tips and tricks. You have to be absolutely familiar with this gun. This delivery device is not the operation. It's like holding a scissors and a forceps. You've never thought about how you hold a scissors and a forceps in your hand when you operate. You do not want to be thinking about the gun. You want to be thinking about doing the operation on the screen completely. And a few of our colleagues have kind of taken that on board this week, and it's nice to see that that's been accepted and taken on. So practice with the clicker until you can keep your face directly on the screen and not have to look down once you're ready to deploy the Eurolift device at the gun. You should not have to want to have your eyes down off the screen at any point in time. All the motions have to be deliberate. There are lots of training aids that you can do before every case, even just to familiarize yourself with how the gun works. And all of this trivial points, they're not trivial, but they are very definite endpoints. They have to, 4 different actions have to be performed in a very distinct manner. Now, starting the paradigm shift. So between TURPs and Eurolift, TURPs is all about the posterior. Forget about that. The paradigm shift this is all about the anterior. It's all about the anterior third, and you will get great results. And one of the things that came out in discussions today at the Kokilabed Hospital with some of the colleagues was when you do a big prostate operation and you only do 2/3 of the prostate and you leave one of the lobes behind because you have spent plenty of time, you have a cavity that looks like looks like that, and there's a sliver of a channel. No one ever complains because they say he'll void fine. Yet when you do a Eurolift, you are looking for a TURP type cavity. It's not the same treatment modalities. Let's start thinking about the channel in the anterior third as opposed to worrying about what's happening down below in the posterior 2/3 of the prostate. Leave that alone. That's your treatment option for a different day and a different modality if the patient ever needs it. So let's go and have a look at this. This is a 75-year-old male. He was on anticoagulants, a little bit comorbid. And so this is the kind of person on whom Eurolift device is a godsend because they can get to normal activities a lot quicker, but also get on the anticoagulants a lot faster. And the risks in the medium to long term is minimized absolutely. So sequence of implants. It is a very definite, systematic approach to how you get the implantation done. When you first start, everything is anterior, but it always starts at the bladder neck. I cannot stress the importance of the first 2, what I call anchoring clips, because when you put the first 2 clips anterolaterally, it sets you up for the entire case from there on in, because everything flows from there. The anterolateral clip will tell you exactly where the anterior channel is, and number 2, when you have to do any stacking maneuvers or opening up the lateral part of the prostate, if there is still a bit more of a bulge at the bladder neck, it will guide you as to how the stacking, the procedure of stacking starts from those anteriorly placed initial clips every single time. So please pay a lot of attention, take your time, and be definite about placing those first 2 clips. When you first start, first 20 cases, 30 cases, the treatment sequence should always be the proximal 2 at the bladder neck, followed by the 2 at the apex. And then if there is a bulge in between, then that will help you decide whether or not you need another clip or not. It's only with experience, and I was 300 deep before I could put the 2 at the bladder neck, and I knew how long the prostate was, where the midgland was, and put that in and open up the prostate sequentially. That will happen for all of you. Just bite your time, and your hands will tell you that I know exactly how this prostate is going to behave and when you can start putting the midgland clips if you ever want to do it that way. But if you start this way, this is very safe, and it will give you a continuous channel anteriorly most of the time. This is an example of how you then put the midgland clip if you need to. The treatment of the median lobe, it's a very specific technical exercise. It is no different to how you deploy the device, but the maneuvers of how to and what to get moved aside, as you will see in one of the videos, is very specific, and it's a bit more technical. The patient will require a catheter, So do not take, I would advise you not to possibly take that on in your first 20 to 30 cases, because the patient will have a slightly more prolonged recovery. Not that you can't do it, anything can be done, rest assured, but I wouldn't advise it in the first kind of 20 cases. Now, is the video? All right. So this is that gentleman that I spoke to you about. We're going to watch the video, a 68cc prostate. One of the things I'm going to get it out early in the piece. The way to think of how many clips to tell my patient is going to need is for every 10 to 15 mils cc's of prostate, you need about 1 clip. So here we are in the bladder. All the movements, the rotation and the angulation happens inside the bladder. When I'm trying to smooth the mucosa, I'm not jamming my device up against the mucosa. It is just a feel with the gun to smooth out the mucosa to find the enterolateral channel. When you found it, coming back 1.5 centimeters, it is almost as easy as letting the bladder disappear in the background, and then for good measure, just come a couple of millimeters further back, and you'll be well and truly safely inside the prostate channel. So as you can see, I'm trying to smooth the mucosa out on the other side, and I have not jammed my telescope up against it. I have just, therefore, then found where the anterolateral edge of the prostate is, again, doing that. And this gentleman has an asymmetrical lateral lobe. On this side, there is more of a bulge straight underneath my device, and that I thought would need a stack to open that up. And when you have to stack the clip, this clip that I'm placing right now, the second clip, is crucial because my stacking maneuver that I'm going to show you straight after this is completely dependent on where this clip ends up, because it has to end up in the anterolateral position to be able to create that anterior channel more definitively. So I have now, the next maneuver is to find that initial clip, which is there, then 1 centimeter down. I'm not putting my device randomly into the lateral lobe somewhere to try and move it sideways. I have found that initial clip 1 centimeter down, 1 centimeter back. What I am doing is I'm pushing the meaty lateral lobe part of the prostate even further down. Leave that for another day. That goes even further down, and you're trying to create that anterior channel that's going to serve you the purpose of getting this patient good outcomes. So 1 centimeter back, because you want this clip to end up in line with the initial clip above it. And you can see when you fire the gun and finally cut the clip, the prostate disappears away from you, and your device stays there at the same place, the plantation device, which means the device is doing the job of moving the prostate away. It's not your compression, so don't feel like you have to jam your working element up against the prostate very hard. It's only a 20-degree compression, in fact, to get the prostate, the needle straight. So I normally don't look for the berry. You have marks and calcifications, as you can see on the screen, that will guide you to where approximately the apex is, and you come in and interlaterally towards the lateral part to keep the mucosa smooth. Don't go bottom up because you're squashing mucosa up there that you don't want to. Always make it symmetrical on both sides. So I'm then going to come in, and you can see I'm mid-gland. I've got no compression on the prostate at that point. I'm just looking. This is a video for presentation, so I was looking for the veru more definitively. Normally, I don't look for the veru. You will know where the veru is, but stay nice and close to the veru. Kiss the veru, look up, and implant. Don't move forward into, because if you move forward by 0.5 centimeter, 5 millimeters, your clip will be mid-gland. You don't want it to be mid-gland. You want it to be apical to create the channel. And see, right now, when I deploy this device, I can see the channel behind me already. You can see the and so again, people keep looking down. Look up, and you can see the channel from the veru. I will show you the veru right here. Lift your hand up, and you can see a channel into the bladder. Please stop. At this point, your job is done. This gentleman will void. He's got a big prostate. So when you talk about reoperation rates, it is the guys with a slightly bigger prostate that over time are going to mirror that 7, 8, 9% reoperation rate. That is a keen, slightly more than a TURP. That's where the difference is, because they're going to continue to enlarge the prostate a little bit faster. So this is the second case. Now, this is what I presented in master classes. But this is a gentleman with not that big a prostate, but he has a component of middle lobe, and we kept this case on as a presentation because it shows you in lifetime, helps me tell you that even everyone, all of us will have to adapt within the implantation of a case, what you're going to do and what you're trying to achieve. What you plan to do doesn't always play out completely seamlessly at all times. This gentleman has a mucosal bridge in the anterior part of his prostate that I had to treat or tear a little bit. So he had a bit more bleeding. So this case, this one is a little bit more edited in terms of the finality. And so this gentleman required a catheter and a bit of diathermy. So you tell them that your recovery is going to be a little bit longer. So always start with a pretty empty bladder. My hand movements, I'm barely holding that gun tight. Don't squeeze down on it. You can move the prostate around reasonably well as long as you're not jammed up against the prostate. And so this jump, no matter what, even if you're going to treat middle lobes, you do your standard implant first. Every single time you do your standard implant first. And so the rotation and angulation happens inside the bladder. The pitch is determined by where you're sitting and where your anterolateral part of your prostate is outside. But you keep everything level when you first start and then decide what pitch you need to be at in terms of your hands going up and down. Swap hands to do the contralateral side. Get a habit of that. Get your left hand working. As I found in robotics, initially you don't find your left, it just sits there and you're operating with the right hand mainly. But this one, you've got to learn to operate with both hands. It will serve you so much better in the long run. Again, bladder disappearing in the background, 20 degrees of compression, depending on the size of the prostate, sometimes a little bit more, and you determine that. So as soon as you see the white line, straighten out into the bladder, empty the bladder, and start with a very, very minimal inflow. That way you have minutes to put the implants in. So this gentleman, at this point, I'm trying to see if I'm going to get away without treating this middle lobe. He has a beautiful sulcus laterally, and I thought, all right, it looked like it may settle down with the stacking on the patient's left-hand side. So that is my plan here. Instead of treating the middle lobe straight away, I'm trying to stack. There you go. I'm trying to, at this point, stack that middle lobe and trying to bring it and flatten it out to see if I can get away without doing the middle lobe. And again, you change your plan intraoperatively to say, what can I achieve? And as you can see, my hand is pitched up pretty high at that point. But if I drop my hands at that point, the tip of the gun will not change. So you have to pitch up to get laterally, sometimes depending on how big the middle lobe is. So that's the stacking. I've come into the bladder and I've decided that whatever needs to be done at the bladder neck, at this point, I need to complete my standard implants. I've come to the bladder, to the apex. He has this mucosal bridge that for some reason, from previous infection and inflammation, that I, in implantation, tore. And then I was trying to get that compressed, the veins compressed by putting the clips in that area. And that is why I'm a little bit more distal than I would like to be at the apex in a normal implant. So as you'll see that when that mucosal bridge tore, when we come in, there's a little bit of bleeding, as you can see right there. So he needed a bit of diathermy to that. And then he was catheterized as you can see, my hand movements are slow but definite. At the time of the implant, you got to keep your eyes on the screen and not on the device at any point. So this is now at this point I can see the bladder from where I'm sitting at the apex. That's what I'm trying to show myself and you. But and that sulcus that was really big has settled down to some degree, but then Michael, who was with me at the time, said, look, why don't you do the middle lobe, because this case has been recorded, and I convinced myself that there wasn't enough of a channel, and that I proceeded to doing the middle lobe anyways. So doing the middle lobe, do not start counting from the end of the middle lobe, come into the prostate fossa, find the anterior anterior bladder neck, then 1.5 centimeters from there. What you're trying to do is you're trying to roll the intravascular component to the side. You're not trying to pin that to the side. And as you can see in this gentleman, at the end, there was a channel that allows that's moved that middle lobe and tacked it to the side, and you've got a good channel there that you can see from the bladder neck, from the apex to the bladder. So there we are. Can we put some more clips at the apex? Yes, you can. You can put as many as you want, but if you're sitting right at the end and you can see that channel, you call it quits. So there we are. That second one is truly a real life difficult case, but you continue and you get to the end point that you want. You cannot rush, because putting the clips in is a very definite thing, and you can get behind the 8 ball if you rush. You have to be definite about the first 2 clips and where they're going. In the smaller prostate, those first 2 clips are even more important, because sometimes they only need 2 clips anterolaterally to get the outcomes. So in terms of the outcome measures, look, this is my data in the initial series, and the reason the company loves putting the screen this data up is to say, even somebody in a remote place with 30 cases can get good results, and they are sustainable. That's what I'm trying to show over the next 4 or 5 years from there on in. There's enough data in terms of showing the efficacy and durability, the safety and lack of complication and reoperation rates, which will hopefully be borne out, firstly from my data, but some of the studies that we are doing right now in our public hospital, where we're comparing UroLift to TURP between the 40 to 80 cc size range. Post-operatively, if I'm not going to put catheters, which is in 95% of cases, the cases that definitely get a catheter are the guys with prostate volumes over 100 cc's, those that have a middle lobe, and those that come in retention. Otherwise, my aim for everybody is to not be catheterized. At the end of the case, I put in a concoction of lignocaine and sodium bicarbonate, 40 mils. That information is available, what you want, with the Teleflex team. They have my exact performer of what that is all about. And everybody goes home on 2 weeks of anti-inflammatories and alpha blockers, and they stop. They have a month of nothing, and they do an IPSS when they come back and see me at 6 weeks. They only get beta agonists, something like Betmiga, Mirabegron, only if they have nitrogen instability type symptoms before they came into my practice. So top tips. I like to spend a bit of time here. So the paradigm shift today, take it from me, is it's a different operation, and the aim is anterior. Do not worry about the tissue posterolaterally. You are not doing a TURP. I said that about 8 times today in the talk. I said, but you're not doing a TURP. You're doing a UroLift. You've got to think about doing a UroLift. And if you're thinking about doing a TURP, then you've brought the patient into the OR for the wrong operation. So think about the anterior channel. Slow is fast. Put a little bit of inflow in. You have got many minutes to put every single clip in, but the clip placement needs to be absolute, with your concentration purely on the device and not on the gun in your hands. Flexible cystoscopy helps the patient always, but it advises the patient what you can achieve, but it helps me plan the procedure. And here I'd like to take a couple of minutes to give you that kind of 4 prostates and 4 plans. Firstly, I talk about the small prostate that's got the V-shaped lateral lobes and the slightly high bladder neck. All you're trying to do there is move the anterior prostate up relative to the bladder neck. And that's how you're going to create a channel. If you sit at the Viru after the 2 implants, then you can see into the bladder. And we did that at Ames. Dr. Mitchell put 2 clips in a 35 or 40 cc prostate with a short prostate, and he sat at the Viru, and he could definitely see in the bladder. And I'm so glad he said that he was convinced this is going to work, because if you put any more clips in there, it would have fish mouthed the bladder neck, and you start getting behind the 8 ball. You can't put more clips in and just take them out. So you have to decide whether you're going to put more clips or not. Less is more. If you put less clips in and you see the bladder, please convince yourself to stop. It'll be hard to do if you're coming from a TURP type situation, but that will over time play out, because it's already started to happen in the last week while I've been here. I don't do hybrid procedures. Hybrid procedures is where there's a hard bladder neck and you do put some UroLifts in and then cut the bladder neck. I stopped doing it because if it worked, it was great. Everybody had the warm and fuzzies and the patient went home. If they came back and it didn't work, you weren't sure what didn't work, whether the UroLift didn't work or the bladder neck incision didn't work. And then if you had to take the patient back, where were you going to start? What were you going to do? And that incited a bit of fear in my mind. So I do a pure UroLift each time and tell the patient there is almost a 90% chance you're going to get away with a couple of clips and a pure UroLift procedure, quicker recovery, early return to normality, and preserving sexual function completely. keep your fluid rate low. It is right at the end when you want to see the white line, you may want to turn the inflow on, but the clip device implantation is almost about to finish. It doesn't matter. But if you have it really trickling in at the initial stages, you have got many minutes to put a device in. I normally say approach in Australia, I say approach a smaller prostate with caution. I think the Indian cohort is going to have the world mastery in small prostates, and I look forward to their talks over the years where I'll be educated about how to manage small prostates moving forward. Thank you, team. Now I'd like to take some questions and then we will proceed from there. Over to you, Dr. Sanjay.
Good evening again, and thank you so much for helping us out with the voice change, which actually made the whole presentation look quite clearly audible. So I have some small questions and comments while I wait for Abhishek to take over a little later, and then probably any questions which would come up from the wonderful audience who attended. So thank you so much again. Number one is, did you say that urodynamics could be optional? I thought urodynamics is the requirement here, because if the bladder does not have that power or it's a hypocontractile bladder, my anxiety will be on putting a lot of money into a procedure which could be then be a challenge to us in terms of a new indication that we're taking forward.
By all means, sir. When the doctor from Bangalore said he did it every year, said if you have the know-how and the setup and the ability to do that, it gives you complete information in terms of what you're trying to achieve. I personally, I don't do it. And if I'm treating, a lot of the guys I'm treating are in the early part of the journey in terms of BPH. They are not end-stage guys. So I don't routinely do urodynamics, but certainly it gives you that information and that reassurance that you're doing the right operation if you're going to spend the money.
I was actually amazed with the wonderful tips and tricks that you had, which actually gave us a lot of convincing into what we have been doing. We got polished today umpteen times more in a single case compared to what we have done in the last 9 to 12 months at the Kokilabin Hospital. So can I just add on to this, which could emanate some questions around, is that back home, myself and my colleagues may have looked into the indications now to bring into this minimally invasive surgical therapy could perhaps for me be 2 or 3 or 4. Number one is those individuals who in their late 40s and 50s land up with a health checkup and suddenly find their prostate is 30 to 60 grams. And they are referred to a urologist in the city or in the country. And when they reach there, the way to take it forward is after a clinical examination. The uroflowmetry is flat, poor, or not in sync with what he says is a good flow. These are the patients who don't know about themselves. And to treat them and to talk about the whole prostate story is to know that they have an obstruction which you're not aware of, which is gradually with a prostatic occlusion happening around. So that's one indication where a uroflowmetry is very poor. As you rightly said, you did a flexible cystoscopy, gave them a trial of alpha blockers. These patients have to be on a very long therapy if you put them on medications in their late 40s and 50s. Number one. Number two are those patients who in their 50s, 60s are on medical therapy with our colleagues across the country and the world, failing therapy. They stop medication for a few days by mistake when they travel on a holiday and they find themselves very difficult. That means medicine is keeping them floating. The flow rates may be poor. They're okay with that. Probably they're on moderate therapy and the doctors have convinced this is the best that they have. Number three are those patients who have got huge amount of comorbids and who may not get a chance to go back to the operating room with a good anesthesia and a long procedure, even in a moderate to small gland, which is anything between 40 to 60 grams prostate. And finally are those patients who are on catheter, and catheterized patients are not getting their catheter out for reasons best known in such situations where we cannot remove their catheter. They have a poor ejection fraction. Like the patient I discussed with you, 54-year-old male with a 50 grams prostate, ran across the city with 20% ejection fraction and could not get a catheter out. And we all got convinced that that was only attempt to get him out of recurrent UTIs. He would not accept a SPC at the age of 54. We took him under local anesthesia, and your tip of the trick, the slow is fast, was in my head 1 year ago when we did this 20-minute procedure under local anesthesia and verbal and local anesthesia, and removed his catheter approximately 4 days after, and we found his flow has got better with the 4 clips that we placed. So looking at these 4 indications, trying to Indianize the way of switching into the right indications and the right approach, because our colleagues and our students whom we teach TURP on one side and on the HOLEP, We know we have got sizes of sheets as 24 and 26. We need to respect the Indian urethra by not having a long dwell time and having injuries. We have gone to 22 for TORPs too, but 20 size sheet from the Teleflex doing a Eurolift for 10, 15, 20 minutes can even suffice a tighter urethra and a prostate which is occlusive. So I was just looking at my indications on patient as to whom I can give one and whom we would hold back. I think we have miles to go before we actually find our own indications, be able to convince ourselves and convince our patients. I was looking at this because, yeah.
Carry on. Here you go.
So the other one is Save the Bladder Project, which is in my head. When we look at this, the normal looking healthy bladder in some cystoscopy, and we look at somebody with medication for a long time and a grossly trabeculated bladder, and we look at in between people who have got no idea about their prostate being grossly occlusive, convincing them on medication which would relieve them for a day, week, month, year, or a decade, but they have long decades to go. This could possibly be a good switch in as a therapy, where who knows, I would ask you the question about what is the 5 years and 10 years data that you already in 8th to 9th year into the 700 cases around, as to what happens to these people in their 3, 5, 7 years. Do they require an alpha blocker therapy concomitant? A question which must just have come.
Yes, it has. So that's you put it so well. I'm going to make a couple of different comments here. First of all, this therapy is so good for the really young and so good for the really old. The young fellas, even as we spoke of today, Dr. Sanjay, in India, people probably don't want to talk to or don't talk about preserving sexual function. But if you close the door and ask every male, I'm sure they would have an opinion about preserving the sexual function. So that is, do not downplay that. Have a frank discussion with them about it. The older fellas, because and the young fellas also, the return to work early is such a little carrot you can dangle to say, you will be back at work doing whatever you do. And where I live, there's a lot of laborers and farmers that need to do heavy manual labor, that they want to get back to work, even at the slightly higher risk of taking on a reoperation rate in the future. Now, a well-placed device implant shouldn't have any more higher reoperation rate compared to a TURP is what I'm trying to get at. And hopefully that's going to bear out over time. The older generation is where they definitely can get off the anticoagulants and get back on the anticoagulants with minimal delay time is a real benefit. And the fact that it can be done at local or a little bit of sedation is a real winner for this modality. In between, you can choose. The reoperation rate in my 700 series is looking at around 6.7% without changing any subgroup analysis or anything like that. But I think, as we all do, we want to cheat, we want to make something look different. And I think without cheating, I think that 40 to 80 cc group is going to have a reoperation rate that is significantly smaller than the guys above 80 cc or 80 or 100 cc and more. They are the guys that are usually having the reoperation. That's because their prostates are enlarging a little bit quicker. So that is the sort of thing you advise the patient in terms of what they're likely to develop, can achieve in 5 to 10 years moving forward. And in that small, normal size prostate, 40 to 80 cc prostate, as you go forward, you will find that you will treat more and more guys. So at the moment in the Indian scenario, you're going to take on a slightly higher risk in terms of younger fellas who needed or wanted, like you described, the older gentlemen and the ones in retention. The retention patients are the most pleasant patients to treat because they are so thankful for the fact that the catheters come out and they're voiding better than they were before. And then in the middle, that's the group you will find once your confidence builds. I have been going on and on about the end game of BPH treatment is bladder preservation. And I'm so glad to hear that from you this morning. And the bladder preservation theory is I don't see trabeculations and ever tell anyone to have a urolith prophylactically. But if they have symptoms, I say to them, you want to get this prostate opened up more than what medications can do before you start getting the trusor instability symptoms of urgency and urgent continence. And the bladder becoming weak, damaged, and its symptoms showing is like aging. You tell me that your waterworks are fine, but if it's like looking at yourself in the mirror every day and you don't think you've aged until you see a photograph from when you were 10 years younger and you think, oh my God, I am a little bit older. So you can show them that the fact that the voiding symptoms have deteriorated by the alpha blockers, then say, look, I can Photoshop this and make you a whole lot better than you are right now and make your voiding like you were 10 or 20 years before with minimal downtime. So we also talk about episodes of care. The episode of care with UroLift when compared to TURP is not on the day of the operation only. It's not on the day after with needing a catheter or not needing a catheter. It's about early return to work, preserving sexual function. These guys have lack of no bleeding, no lack of catheterization, lack of infective complication, lack of strictures, no bladder neck contractures. All of that, when put together over a 12-month period in the medium to long term, makes this procedure that the patient should value if they value comfort in terms of getting their health looked after over a period of time. So that is the paradigm shift. Anterior treatment and a treatment at an earlier time with less undertaking is the benefits of what UroLift is trying to provide.
Yeah. So the thing was that you convinced us and that we finding results around, you have stressed on that point, the treatment is all on the anterolateral anterior approach.
Yes, sir. 100%.
We have this,
and so
yeah.
When you put the anterolateral clips and you've got that first channel, then when you sit at the veru and you can't see the bladder, when you want to move the lateral part of the prostate, not even the post, I never say posterolateral. I don't use the word posterolateral prostate. It's got nothing to do with UroLift. When you want to move that lateral part of the prostate, resist the urge to think that a one-clip device randomly put somewhere in the lateral part of the prostate is going to suddenly drop the lateral part of the prostate away from the midline. That's not the function. You have to find the anterolateral clip, then come systematically down and compress more of the prostate down further and augment the anterior channel even more. You get the benefit of the UroLift device. It's not randomly. I have a couple of colleagues have put in devices into the lateral lobe and posterolateral lobe, hoping that the whole thing will just suddenly get away. And those implants have disappeared into the abyss of a sponge and never to be seen again. And I did indicate in that city that I said that's the best 1 lakh rupees ever wasted because it will save millions in the future. So it's a very systematic approach to how you stack the anterolateral prostate to open up that channel coming back towards the veru. And at the veru, the distal area, you never have to stack. There's not enough prostate there to stack. If you've got a little bit of a apical tissue, do not think that that's going to have any bearing on the patient's urodynamic flow. There are doctors, Peter Chin, who's my mentor. He does the 4D technique, which is just on a 40cc prostate, we'll put the anterolateral and the stacking lateral ones, 4 devices in 4 different directions. And that's all he does. He sits at the veru and pokes at the apical prostate. And when he can see the bladder, he stops. He says that's the apical tissue being together is what preserves the ejaculation. I don't believe that, but he doesn't treat that apical prostate at all. And he gets the results just as good, if not better. He's my mentor. So do not start to make it look good for you because it's lakhs of rupees spent in making it look good, but it's not functionally any better.
So Dr. Kiran, Dr. Kim Mamin is a senior teacher to us in the country, and he has got 2 questions which you have partly answered. But to take it forward, do you give alpha blockers before UroLift insertion? And I'll add on to it that, do you continue alpha blockers if somebody is doing well and you convince that alpha blockers is a good way rather than getting him on a UroLift that is borderline? And number 2 is, do you give 5-alpha reductase inhibitors along with alpha blockers? And if then, how long would you give and would you continue them forever?
So, sir, I'm not a big fan of 5-alpha reductase inhibitors because at least in the younger cohort, because at some point in Australia, which is very litigious, second only to California, I keep saying in Australia that somebody is going to get sued because they put them on dutasteride, they lose their sexual function, they don't recover it, and they will say, was there something more minimally invasive available? So the sexual side of the function side of things is a big issue in Australia. and somebody's going to come unstuck. So I personally steer away from it unless this elderly gentleman that wants to avoid, then I keep them on what we call Duodart over there. As far as alpha blockers post-operatively is concerned, 2 weeks, and then they have to stop. The device should do the job. Give them a good couple of months for it to settle. At 6 weeks, majority of the patients are where they're going to be, and they're going to be happy. And if anything drives the IPSS at that 6-week mark, in my practice, is the urgency that, I've got to go more frequently at the moment, and I put them on a month-long trial of beta agonist at that point, see them again in 1 more month. I don't know if the beta agonist does it, but just a little bit more time, and they're all good, and then most of them go home at that point. So I don't continue.
Got it.
A
Abhishek,
point
yeah.
here, which is, sir, which seems a little, I can't hear, sir.
Abhishek, go ahead.
Yeah, so the point that I think is extremely controversial is not using 5 alpha reductase inhibitors, because we know the only drug which has the potential to change the trajectory of or a natural history of BPH is 5 alpha reductase inhibitors. Alpha blockers, we all know that don't change the natural history of the disease. They are absolutely temporarizing measures. So, so my submission that it will be from a literature standpoint, it may not be the best suggestion.
Sorry.
So, Dr. Kiran, Dr. Abhishek, my colleague, did talk about the aspect of we having relied on the 5 alpha reductase inhibitors for decades on understanding that changes the natural trajectory and history of the prostatic volume growth, which is one aspect which is expected in due course of time for the patients who would get that. So would it not be controversial for us as a junior level to look at years later, while we have opened the passage anterolaterally, they could look forward to a progressive natural growth which could happen around. And therefore, textbooks and teachings across has been that 5 ARIs are helpful towards changing the entire path and pathway of prostatic enlargement, occlusion, growth, which could probably be at least touch based upon by continued 5 ARIs while we have opened up the channel by the clips or the implants. Is Dr. Kiran around, or he has got disconnected by an attempt that was happening with Dr. Madhu? Anirudh, as Dr. Kiran got disconnected during the Q&A.
Can you hear me?
Yes, you're back.
All right, so that's great. Look, I think if the patient is willing to tolerate, and if they're tolerating the 5 alpha reductase inhibitors as well, by all means, I think the aim of this device is to minimize the number of medications the patients are on. And the elderly guys who don't worry about sexual function, if they want to stay on 5 ARIs, by all means, I think the landscape's changing. Even though we're doing studies on certain things, moving forward, what we were working on may change entirely. I mean, there was some recent data from the UK about how the URL device is probably not as good as they thought in terms of their data coming through in the NHS. It'll have to be borne out who's doing the procedures. And because, like I said, this morning and this whole week, there is a little bit of artistry to how to get this procedure completed. The science is there, the mechanics is there, but in how to get a good channel and what you're trying to achieve, there's a little bit of artistry, and that's the nuanced way in which this technology works, which has to be taught, learned, and moved forward.
So what is the retreatment rate at the end of, say, about 2 years? When we were doing the Aquabeam trials, in the first 50 cases, they were about 10%, and then they decreased to 8%-ish. So what are the retreatment rates, and what is a good modality? If you do a conventional TURP, are you able to cut through those tines? The threads?
The reoperation rate is around 6.7% in 700 cases, right? And this is very, very, I've kind of looked at it, and just on a rough estimate, it's about there. It starts off higher, slightly higher. So you quote up to 8 to 9% at 5 to 10 years. The data it's a little, the time frame is a little bit broad. Most of those guys are going to be the slightly bigger prostates. As far as how to retreat, I have done a number of urolifts in most of these guys. And because the question I asked the patient is that initially when we did this treatment, were you happy and satisfied and have the symptoms gone backwards? And they say yes. I said that is an option. The company shut their ears when I say that, but I have done it and the patients are happy. As far as doing a TURP is concerned, you can do a conventional TUR, and the only thing you have to be careful about is when you find the urethral end piece and the suture, do not try and continuously burn it with a TUR loop. Your loop will blow, and you'll end up spending more money on the loops. But if you use staccato current that cuts through the urethral end piece very easily, the nitrile suture, I don't tend to go digging around for it. It retracts a little bit into the prostate fossa and doesn't cause any issues. So the true enterolateral clips that you initially place, a lot of the times they don't even come into the view when you do a conventional TUR, which really tells you how enterolateral you truly are, because they don't, unless you start to cut, open up because of 100% anteriorly, which probably I tend to not do to just decrease the bladder neck and stricture rates. You don't even come in contact with all of the stitches. If I put 6 stitches in, normally I come in contact with a couple of them, which is where the ones that are stacked, the lateral ones, those are the ones that I come in contact with, and you just cut it with the normal, you can use lasers, or lasers probably a little bit easier, but the bipolar diathermy with staccato current treats it reasonably well and easily. You're just muted, Dr. Abhishek.
Abhishek, you're muted.
So Sujata madam wants to ask whether urodynamic studies have been done in the long-term follow-up or a medium-term follow-up.
No, we haven't done so. No.
Okay.
I'm a very practical working urologist. Once the patients are happy, and the beauty I have is that because I'm in a remote place, most of the patients will come back to see me. And if they've gone to see one of the other 2 urologists, I usually are collegial enough that they will let me know, so that I keep a track on the data of who has had retreatments somewhere else. And because they all know they've done some research on my numbers. What's the question? I forgot the question.
So that was a question regarding improvement. What are your endpoints of looking at a patient has improved? On one side, we are convinced, like we did the Creeds and the Waddles maneuver on the table, and we were happy about the urine flowing onto our body, which is a good flow that we get convinced around. What are the benchmarks and points that you look at on one side that patient feeling good?
I truly look at IPSS, and I look at the channel I've created with minimal inflow. If you sit at the Veru, you see the bladder, you have to trust the natural process, dropping the bladder neck, and the bladder being nice and full will give you a good flow. This is, urodynamics was the question. I don't do urodynamics. If the patient returns to me, and before I do a repeat procedure, I certainly get Dr. Walensky, who's my colleague, do the urodynamics for me, and then returns the patient to me. He used to be my resident, so he still looks after the old boy in that sense.
What is your advice on individuals of the kind who belong to the group of long-term catheterization, and we are doing like the one I did discuss with you, doing a urolift, the catheter removal technique? Do we think a good channel has been created to remove the catheter next day, or I still wait for some more time?
I don't. So Mark Rochester's got a big study, 80 odd patients, retention patients. I think that is going to grow because a lot of people are now catheters, acute retentions don't scare people anymore. I love it because I know that this is going to be a very thankful patient with minimal fuss. If you've created a good channel, I put them on anti-inflammatories, leave it for 5 days minimum, and then take the catheter. Sometimes I do 3 days because if I'm operating on a Friday, then my girls have Monday all day too. So it's a practicality issue. But I don't think the next day is a good idea, because when you implant, you're going to get a bit of swelling as well. And you probably find that they will all end up in retention within a day or two, even if they failed, even if they pass the trial good on the next day, they'll go into retention in a couple of days' time. It just makes it more traumatic. Take it out 5 days later, and you'll be very safe and fine.
Got it, sir. That's
Yeah,
good. That's great. Tell us about what is the maximum number of implants you may have put or would be required to put in a gland which is inching towards the approved US FDA indication of 80 grams in somebody whom we can't operate. I put 5 implants in somebody, but we saw 4 today and we are okay with it as the optimal one. Go ahead and tell us your tricks.
So the plan goes small prostate 2 to 3, normal prostate 40 to 60 cc, 4 implants, 60 to 80 cc. I go bladder neck, mid gland, apex, so 6 implants, and then 80 to 100 cc all with middle lobes. I stack the bladder neck and stack the mid gland, or if they have a middle lobe, don't do the stack, just treat the middle lobe and put a couple of extra stacking ones. So by the time you've got to 10 implants, so 100 cc prostate, 10 implants. If you've opened the 11th implant, not that I'm saying you shouldn't use 11 implants or 12 implants, you can use as many as you want. But if you systematically place it, in my head, I just don't have many more places to put more implants in the anterolateral channel. Again, the most implants are used when people randomly decide, I'm going to move a bit of this lateral lobe aside, and then you can put 20 of them. They'll just cause little holes in the prostate, but they're not going to systematically move the prostate out of the way. So if you've done 10 implants, do not open the 11th one. After 10 systematically well-placed implants, the patient will void. It might take them a bit longer because they've got a bigger prostate. But if you're starting to put 12, 15, you're barking up the wrong tree. You've missed the mark. You brought the patient for the wrong operation. You're going nowhere with that in a hurry. So that is the less is more theory. At 1 clip for every 10 to 15 cc of prostate volume. That's your benchmark. 1 here, 1 more, or 1 less is the kind of give or take criteria. And when you see a channel, I'm so glad what you showed today, the maturity in going, yep, I'm convinced that, there's the fossa is open. There was a little bit of that middle lobe, but you could see the bladder that will drop by itself, and the patient will void. Is the sensibility of it all. Less is more.
So the question would be, if you put too many implants, you actually could create the bladder neck into a vessel kind of thing, and then you'll be lost.
That's for the smaller. In an effort to trying to be nice to your patients and wanting to do more for your patients, putting more clips is the wrong thing to do. In fact, you're doing them a disservice, because if you've got those 2 anterolateral ones and the anterior part of the prostate lifted up against the bladder neck, if you put any lateral clips, it will raise the middle, the bladder neck towards the anterior part of the prostate even more, because you'll make a slit out of it, and you don't want that. I just say put the 2 anteriorly and let nature drop the bladder neck a little bit, and that will help the patient void a lot better. So yes, in the smaller prostates, resist the urge to do more for your patients. Doing less is doing more for the patient.
Thank you so much. It has been very convincing. I personally have polished myself umpteen times today on the process that I've been doing for the last year and a half. But really convincing on those small tips and tricks in the operating room today by you. And then to a very large audience today, to our respected colleagues who are finding their ways out into this minimal invasive request from patients around. I think it has been very convincing. It's all about we taking this subject forward to the next level. Thank you so much for being in India, handholding journey on various attempts that you have done. And thank you, Teleflex. Thank you, USI and ISU, for giving us an opportunity to interact with you, looking at your experience. I think it's all about, if we always do what we always did, we'll always get what we always got. It's time to switch over and probably understand where can we bring in some new indications rightfully as required. So thoroughly convinced, it's all about we have to take the tips and tricks to our colleagues who are patients across the table to be able to convince them, number one, to convince ourselves that we can do the procedure so much of issues about keeping your eyes intact onto the monitor, as you told me today, which I was missing out after a little short stint abroad. But very impressed on the way you have taken it forward. The very crisp slides which talked about tips and tricks was good enough. I will leave it to Dr. Abhishek to give the final comments and then close this webinar thoughtfully. Very, very, very well thought of. Thank you again, USI, ISU, and the platform.
Thank you very much, sir. It is indeed set the platform for people like newcomers into this particular realm like me to take up this particular technique. It is going to be a good thing for a selected subset of our patients. Thank you very much.
And I would like
Madam,
to thank
can we close the madam,
Yeah.
we can close the proclamation.
Thank you, Dr. Kiran, on behalf of ISU, Indian School of Urology and USI, for your participation and for the nice demonstration. We look forward to more participation from and more interaction with you. And thank you, Teleflex, for your participation with ISU. Thank you, Abhishek and Sanjay. And good night and have a nice time. Bye.
Thank you, everyone. Namaste.
Bye.
Oh, boys.